Hello, everyone. I'm Wendy Stock. I'm a professor at the University of Chicago, and it's my pleasure to present to you a small talk today on treatment of first relapse of adults with acute lymphoblastic leukemia, particularly focusing on my current thinking and approach to this area. These are my disclosures. As many of you know, in the past, treatment of relapse of adults with acute lymphoblastic leukemia has resulted in relatively poor outcomes. These are slides. Slide is a table from a number of different trials, mostly from the past, that show that the response to traditional chemotherapy once patients have relapsed with acute lymphoblastic leukemia is relatively low. And response rates are in anywhere from the 15 to 40% range. In particular, what we see is that, as you can see in these circles, that the older adults with relapsed ALL have had particularly poor outcomes. Most of the studies, as you can see here, were done in younger patients. And even in the younger patient population, the results were not particularly promising. So this again just shows the problem, the poor outcomes of patients, regardless of age, really, with acute lymphoblastic leukemia once they relapsed. This is now for good news has changed, and we're doing a bit better thanks to the addition and introduction of a number of very important new agents in the therapy of patients with acute lymphoblastic leukemia. We know that the goal, in general, of patients who have had a relapse of treatment is to get back into a second remission and to take them, if possible, to an allogeneic transplant, illustrated here on this slide, showing a decent survival, which now I think is better, for patients who achieved a second or beyond first relapse remission, and then went on to an allogeneic transplant. And we know from recent data that MRD, minimal residual disease detection, is a very crucial marker to predict outcome. And those patients who enter transplant in an MRD negative state, an undetectable MRD state, do best. And as I also mentioned, we now have a number of exciting new agents that have been around now for several years that allow us to achieve the MRD negative second remissions and potentially get people onto an allogeneic transplant with long-term survival. The agents that I'm going to briefly touch on, you already know probably, blinatumomab, the CD19, CD3 BiTE, which has a remission rate in gross relapse of about 34% CR rate. Inotuzumab, overall CR rate of 36%, but overall response rate of 81%. And inotuzumab ozogamicin is a CD22 antibody drug conjugate. You already saw the outcomes for salvage chemotherapy in the previous slides. This is just for comparison. And now we have in the adult population also the availability of an approved CAR T-cell treatment with high response rates also, allowing many patients to go on to an allogeneic transplant. So, as I mentioned, allotransplant does remain the destination, although it's not an option for all patients, and we'll talk a little bit about that, who are beyond first complete remission. And this summarizes what I already just showed you, that new agents are possible and that we're going to discuss a little bit about each of these agents, which you already probably have heard a number of times, but just to put into context. We know that blinatumomab was approved through this phase 3 randomized trial, the Tower trial, comparing blinatumomab with standard of care chemotherapy, which we all know already has a low response rate. Blinatumomab was given, as it currently is, in a continuous IV infusion for 4 weeks, with a dose escalation after an initial introductory period of about a week. In this trial, the overall response rate, as you can see here, was 44%, and compared very favorably with a statistical significant improvement to standard of care. Importantly, the patients who achieved remissions with blinatumomab had a very high MRD negativity rate, which, as we've just talked about, is important for predicting outcome to allogeneic transplant. The INNOVATE trial was the trial randomized phase 3 that resulted in approval of inotuzumab ozogamicin, a CD22 antibody drug conjugate for patients with relapsed ALL. And in a very similar design, patients were randomized to standard of care versus inotuzumab. These are all patients who had relapsed disease and were CD22 positive because inotuzumab, of course, targets the CD22 antigen. In this trial, the CR/CRI rate was very high, nearly 81% compared to standard of care. And again, an exceptionally high proportion of those responding patients were MRD negative. Now, neither trial, importantly, resulted in improved overall survival, and therefore we know that some additional therapy after INO or blina in the beyond first CR setting is essential because the median progression-free survival was only 4 to 7 months. Again, allotransplant is the hope for many of these patients. Now, interestingly, just to provide some context, the pediatricians have done a trial where they combined chemotherapy with blinatumomab. They treated patients. These are all younger adults and children. You can see the median age was really 9 years, even though it included some young adults up to the age of 30, where they first gave chemotherapy because we know blinatumomab is probably not very good for bulk disease. And then they came in with blinatumomab. And you can see that, in fact, chemo followed by blina resulted in improved disease-free survival. So that's another option. But what they found in this trial was that the chemotherapy was quite toxic and resulted in significant adverse events that precluded the moving forward of some of these patients with additional therapy. Oh, my slide seems to be stuck. There we go. And here's the outcomes of these patients. And you can see, again, a pediatric population where you see, again, a much improved survival rate compared to what we were seeing in the 15 to 20% range for adults in the chemotherapy era. Here, these patients who were randomized to chemotherapy followed by blinatumomab versus those who got chemotherapy alone had a superior outcome. And these patients went on to transplant with a much higher proportional rate than those who just got chemotherapy. You can see that 70% went on to an allogeneic transplant in this blina group versus 43% for the chemo alone group. But this was not, as I said, a completely easy regimen. But it may be an approach that we are thinking about more to combine a little bit of chemotherapy followed by blina to make blina a more effective drug. But is this really necessary? Maybe not, because inotuzumab has high response rates regardless of disease burden. And you can see that here, that if patients are strongly CD22 positive on their lymphoblasts, the response rates are quite high regardless of bone marrow cellularity, whereas we know that blina works best in an MRD negative or a low MRD burden state, a low residual disease burden state that may be improved by giving chemo first. Perhaps this might be a better approach since INO is very good, as you can see here, for bulk disease, resulting in very high MRD negative rates, confirming the data that were present from the INNOVATE trial. Now, this is the outcome of those patients who got inotuzumab and went on to an allogeneic transplant. This has been published now as well, and it shows that the patients who did the very best are the patients who went on to transplant without additional treatment after getting inotuzumab. And you can see nice response rates with a nice plateau on the survival curve. There are some issues to discuss, however, about the toxicity of using INO and then going directly on to transplant, because we know that inotuzumab results in a very serious toxicity in patients, which is a veno-occlusive disease or sinusoidal obstructive syndrome. And how to avoid that and achieve these good results is an important consideration when using inotuzumab. And we'll come back to that. What about CAR T-cell therapy? Well, CAR T-cell therapy has recently been approved last fall, about a year ago now, for patients with adults with ALL. It's already been approved for younger patients, 24 and under, with ALL for a number of years, different products. And you can see here from this slide, the data on the CD19 CAR T cells, two of which are FDA approved here in the United States. One from the Eliana study, the pediatric trial, and one from the adult world, the ZUMA-3 trial, both resulting in high CR rates with high MRD negative rates. But again, some issues about getting patients to CAR T in this day and age. One of them is that you can see here, just to show you first, the outcomes of patients from the ZUMA-3 trial, the trial for adults with ALL, who got treated with the CAR T, and you can see their survival. There are still relapses, as you can see. So the question remains an open one about how and when to bridge patients after a CAR T to allogeneic transplant. Since my personal belief is that we still don't have, from the commercial products, good data in the adult world that the responses are durable after CAR T, and that one might still need to move forward with an allogeneic transplant. And I think this is a very important point, because even though the response rates are high, if you still have to come in with an allogeneic transplant, there are additional issues to be considered when thinking about CAR T cell treatment, in the fact that many patients start, but not as many patients get through the whole process. Because ALL is an aggressive disease, it requires leukapheresis from these patients, preparation of the CAR T cell, in the meantime giving them bridging therapy that will allow their disease to remain quote unquote stable-ish before getting the CAR T cell, and finally then getting the CAR T cell. So 77% of the patients who started actually got to the CAR T cell infusion, which is an important consideration when you're thinking about people with very aggressive relapse and needing to do something quickly. So in the intent to treat responses, the important thing to notice is that in all patients, the response rate was 54%, which is really not that different from either blinatumomab or inotuzumab, particularly chemo followed by blina or inotuzumab alone, which had a high response rate, CR/CRi rate. So something to think about, and something that I consider when I'm thinking about whether a CAR T cell approach is appropriate for patients. We know also regarding CAR T cells that they too are associated with best responses when the disease burden is low. And this is from the Memorial Sloan Kettering trial using a product that is not currently approved in the adult world, where low disease burden was associated with excellent responses, with durable responses, even without allogeneic transplant. Similarly, from the Fred Hutchinson data, patient with low disease burden had much, much better durable responses and survival following CAR T cell therapy. And here are the variables here that were important in this Fred Hutchinson study, in addition to disease burden, was low LDH, which is a reflective of disease burden, the conditioning, the platelet count prior to conditioning, and fludarabine added to the conditioning regimen, which has become pretty standard. And interestingly now, at least in the United States, is on a terrible, we have a terrible deficit of fludarabine. And that has complicated further the use of CAR T cell therapy here in the United States and allogeneic last few months of a shortage. Will we have additional CAR T options that might be more durable and not necessarily requiring that patients go on to an allogeneic transplant? Well, there are some very interesting ones that are being tested at the moment worldwide. One is this low affinity CAR T cell. It binds briefly and then it releases. So toxicity is less and T cell exhaustion is less. And in an early report, the durable responses seem to be very, very promising here. And that trial is ongoing throughout the world at the moment to see whether this product really might both decrease toxicity from CAR T cell, which is tremendous in the relapsed refractory setting when bulk disease is present, and improve the durability by allowing the T cells not to become exhausted by constant activation. So that brings the question about whether we can eventually move CAR T cells into the front line, and that remains to be tested, where we really wouldn't then have to go on to an allogeneic transplant. So here's my current treatment algorithm for relapse refractory BALL. If a patient hasn't had a transplant already, and they have minimal residual disease at the time of relapse, a very low disease burden, and have CD19 expression, I use blinatumomab. What if they have bulk disease, however, rather than using chemo followed by blina, I use inotuzumab and then follow it potentially with blina, or go straight to transplant using special criteria, no more than 1 to 2 cycles of inotuzumab, waiting about 4 weeks, using ursodiol to prevent veno-occlusive disease, and never using dual alkylating agents for the transplant preparative regimen. There are some patients with ALL, particularly the mixed lineage leukemias, the KMT2A fusions, that are both CD19 weak and or negative and CD22 negative. And for those patients, and I'll talk about this in a minute, I think about a venetoclax-based regimen, which we'll talk about. And then if they enter remission, I try to take patients on to transplant. If they're not fit for an allo transplant, I consider alternative therapy, for example, POMP, with ongoing IT chemotherapy. If the patients have already had a transplant and they relapse, those are the patients where I'm really quite enthused about using a CAR T cell approach, because you can restore donor chimerism and perhaps get that GVL effect of the donor cells. So those are the patients where I like to think about using a CAR T cell and not going on to a second allotransplant. If they don't express CD19, I use inotuzumab. And again, the same approach if they're both CD19 negative and CD22 negative, if the lymphoblasts are negative. So if they are positive, as I said, I give CAR T cell and would watch. If INO or chemo is used, I have considered a second allotransplant in those patients who have previously had a transplant. I would prefer greatly not to have to do that. And there are patients that I have had, parenthetically, whom we can discuss, who have had transplant, who've gotten back into remission with either INO or blina and have not gone on to a second transplant, but have had some post antibody or targeted antibody treatment therapy, and with good long-term survival. Just anecdotal stories. What about relapse TALL? It's a harder beast to treat for sure. We know that nelarabine, guanine nucleoside, is approved for treatment of relapse. The CR rate is 31% as a single agent. And now we also have some very exciting new data about targeting the BCL2 family, which I'll go over in a bit. Pediatric data suggests that bortezomib containing regimens have efficacy in relapse for TALL. And so far, there are no CAR T cell therapies for TALL, although there are some promising trials ongoing or about to start for patients using CAR T cell therapy, CD7 CAR T in general, for treatment of TALL, and CD38 targeting using daratumumab or a CD38 BiTE that's under investigation may have efficacy for MRD positive TALL, kind of like the blinatumomab for TALL. So just to go into a little bit, the data on how venetoclax targeting the BCL family members may improve outcome in ALL. We have data from a combined trial from MD Anderson and the Dana-Farber, where they combined venetoclax with mini hyper CVD, a chemotherapy approach with venetoclax to help enhance apoptotic cell death. And in this trial, they were able to feasibly combine venetoclax at a dose of both 400 and 600 milligrams to mini hyper CVD. In the expansion trial, 400 milligrams is being tested. And there are very high response rates in untreated patients, but even a reasonable response rate in relapse refractory disease. Small study, not a lot of follow-up yet, but at least some promise. We also did a very interesting trial to me of minimal chemotherapy with two BCL targeting family members, venetoclax to target BCL2 and navitoclax to target BCL-XL, which may be in fact very, very important for targeting in patients with precursor TALL, whereas targeting BCL2 may be more important for the ETP, the early T precursor patients who have a very more sort of myeloid behavior. And you can see in this trial where those two drugs, both oral, were given, followed by minimal chemotherapy, which included dexamethasone, vincristine, and asparaginase, which was given after a run-in of the two pro-apoptotic agents. We were able, in highly refractory patients, many of whom had already relapsed after a transplant, to have an overall response rate of about 60%. And as you can see on this table, patients with TALL had a very promising response rate in addition to the BALL patients. As I also alluded to, CD38 may be a good target for ALL, potentially especially in the minimal residual disease setting. This is a study that shows that CD38 is a good target. It's present both at the time of diagnosis and at relapse in patients with TALL, and in a very elegant series of PDX treatment studies where human TALL, both ETP and precursor TALL, were engrafted into mouse models who were then treated with daratumumab. Excellent responses were noted, particularly in mice with human leukemias that had low disease burdens. And there are clinical examples of daratumumab being used to treat patients with relapsed TALL and BALL, actually. But particularly for TALL, where the drug has shown efficacy, just case reports. But in the United States now, we do have a trial of daratumumab for treatment of relapsed TALL that has just opened for minimal residual disease patients. Excuse me, not relapsed TALL, for patients in remission but with residual disease. And that trial is just starting. What about CAR T-cell for TALL? Well, there are studies ongoing. There are already studies that were reported last year at ASH from China with a CD7 targeted CAR T-cell. And you can see here, median age was only 17 years, younger patient population, high-risk patients, and 13 of 14 of these patients in this report from ASH achieved CR, and all were MRD negative. And as you can see, 11 of 14 were bridged to allotransplant, and with short follow-up were negative. There is an exciting trial ongoing in the United States now of a CD7-directed CAR T. It was developed by the group at WashU, John DePercio and colleagues, and that trial already has also some early responses that perhaps will be mentioned at the ASH meeting this year, I'm not sure. So in summary, allotransplant remains the treatment of choice for patients who are in CR2 or greater. And if you go into transplant with low disease burden, that is associated with improved disease-free survival. And we can now actually get there with the use of these new therapies that I've described in some detail during the course of this talk, the BLINA, the INO, and the CAR T cells. New frontiers for relapsed TALL. Nelarabine is the only approved agent. Therefore, it's an unmet need. Targeting apoptotic pathways, as I showed you, is of great interest. And there is going to be a trial in the United States, we hope, in the next year, where these agents are being introduced into frontline therapy to further enhance response rates and minimize the risk of relapse. CAR T cell therapies for TALL are under development and in active investigation. and already show some extremely exciting results. What about the high-risk group of KMT2A rearranged patients, often CD19, CD22 negative? Well, we also have a very thrilling, to me, opportunity here with the menin inhibitors. Blockade of menin interaction with MLL fusion is a method of targeting all MLL fusions. In order for MLL to transactivate and cause leukemia, it has to bind, MLL fusions must bind with menin. And this menin inhibitor, several are in clinical trials, more under development, actually blocks that essential interaction and prevents leukemogenesis. And very exciting data in the early studies for both myeloid and lymphoid rearranged KMT2A fusions. So with that, I'd like to thank all of you and happy to answer any additional questions. Thank you.